Professor Butler here. Just want to do a quick video on ECG review. Okay, so just a quick reminder, let's talk about what is happening with the ECG. Okay, so first we're going to start with a P wave, then we have our QRS complex followed by our T wave. So this is our P wave, this is the Q, R, and S, and here's our T wave. As we've discussed, the P wave is the depolarization of the atria. So again, the atria are at the top of the heart, the ventricles are at the bottom of the heart. So when the depolarization, this P wave here happens, those depolarization of the atria are happening, resulting in contraction of the atria. So blood is then pushed through both the tricuspid on the right side and the bicuspid valves on the left side into the ventricles. That is what's happening in our P wave. Our QRS complex is now the depolarization of those ventricles. So now that electrical conduction is going from the atria to the ventricles, this in turn causes the ventricles to contract. So our QRS complex is those ventricles contracting, where blood is either pushed through the pulmonary valve into the lungs or through the aortic valve into the aorta and eventually to the body. The T wave is the repolarization of the ventricles when they were relaxed. Okay, so again, contraction of the atria, followed by contraction of the ventricles, followed by relaxation of the ventricles. Okay, we don't see the repolarization of the atria that is recorded on the ECG rhythm. So we're going to start with that. But when it comes to there are 7 rhythms that you need to know, and we are going to go over them here. Okay, starting with, we have got, I like to call it our 3, 1, and 3. Okay, so we're going to start with our sinus rhythms. Okay, and we're going to do 1 tachy rhythm, and then we're going to have 3 cardiac arrest rhythms. Okay, there's actually 4, but there are only 3 that you need to know. Okay, for our purposes. Okay, so let's start off with our sinus rhythms. Okay, so we're going to start off with normal sinus rhythm. So as we know, normal sinus rhythm is between 60 and 100 beats per minute. Okay. So again, determined by our SA node, that internal pacemaker. So normal sinus rhythm will have a P wave, QRS complex, and a T wave. So there will always be a P wave before the QRS complex. There will always be a QRS complex after the P wave, and there will always be a T wave after the QRS complex. Normal sinus rhythm will look like this with 60 to 100 beats per minute. Then we have our Brady sinus rhythm. And the difference between our Brady sinus rhythm is that it is less than 60 beats per minute. Okay. And again, a lot of times this may mean if a patient is in Brady sinus, they still have that P wave, QRS complex, and T wave. The only difference is it is under 60. This may be a problem, or it may not, depending on your patient. If they are a cardiovascular athlete, this wouldn't necessarily be a big deal. However, if your patient consistently has this, it may be something that we may need to pace them, even potentially replace their internal pacemaker and put one inserted surgically. We also have got our tachy sinus rhythm. For a tachy sinus rhythm, it is greater than 100 beats per minute. So again, even though it is over 100, it will still have the P wave, the QRS complex, and the T wave. Okay, so all of these are going to have this, just determines if it's Brady, tachy, or normal, depending on the beats per minute. Okay. Now, we introduced you to a couple different tachys, but the big one that I want you to know is the one that is the most common. Atrial fibrillation, Afib as we like to call it. Okay, as we talked about, this is going to be the most common dysrhythmia that you're going to see. It is very common, right? A lot of our cardiovascular disorders result in potentially Afib. Now, what is happening with Afib is the atria are not contracting, they're quivering. Okay, so think about that from a physiological standpoint, right? So if the atria are not contracting, they're quivering, what happens to that blood as it's allowed to potentially pool in either the right or left atria on its way through either the tricuspid or bicuspid valve, right? As we know, when blood is allowed to pool, it can create a clot, right? So our biggest concern for patients that have AFib is the fact of preventing that clot. Now, we talked about the cardiovascular lazy river, and yes, there is a video regarding the cardiovascular lazy river. But in that case, if that clot were to happen on the right side of the patient's heart, that would potentially end up as a PE if we don't interject with any interventions prior to that. If it's on the left side of the heart, that clot can end up going into the brain and causing a stroke. Okay? But when it comes to AFib, we've already said that the atria are quivering, they're not contracting. So guess what AFib doesn't have? AFib has no discernible P wave. Okay? So we have no P wave, because again, this represents the atria contracting. That is not happening in AFib. So no P wave. So this in turn causes the ventricles to get their electrical activity all kinds of out of whack. So two things that are discernible specifically about AFib is there is no P wave, and we have what is called an irregular heartbeat. And what that means when we say regular is when you look at an ECG rhythm, you'll see P, QRS complex T. Keep it going, we'll have another P wave, a QRS complex, and a T wave, right? This to here is where we're looking, are they regular, meaning are they equidistant? If I continue this on, another P wave, another QRS complex, and a T wave, right? So looking at all of our R to R intervals, right here, R to R, in a normal sinus rhythm, they are equidistant. That doesn't happen in AFib because these ventricles are getting their information and they are contracting out of whack. So on AFib, you will not have a P wave and your R to R intervals will not be equidistant. Sometimes they're shorter, sometimes that they're longer. Okay? When we're really concerned, patients can have both what's called controlled and uncontrolled AFib, right? Patients that have controlled AFib, our biggest concern is what? A clot, right? So our biggest concern are clots. And again, when you're thinking of prioritization, think about the worst thing that possibly can happen. The worst thing that can possibly happen is that your patient were to throw a clot. So patients that have controlled AFib, and controlled means that it is less than or equal to, less than or equal to 100 beats per minute. Okay? But when we're really concerned is when it is uncontrolled. And when does uncontrolled happen? Uncontrolled happens at tachycardia. When does tachycardia happen? 101 or greater. 101, let's just do a plus, right? Equal to 101. Okay, so our biggest concern in uncontrolled AFib, again, no P wave, irregular R to R intervals, not like it would be in a normal sinus rhythm. Okay, our biggest concern is, first and foremost, what's the worst thing that can happen? Patient can throw a clot, right? Either have a PE or a stroke. So we're going to put your patient on an anticoagulant, right? But we got a pump problem. So if the pump's not working efficiently, what is the job of the heart to do, right? The job of the heart is to pump blood. What does that blood do? Gas exchange. Our biggest concern, obviously, is oxygen, right? So in that case, we're going to start with throwing some oxygen on. But what do we need to do? We need to prevent this clot. So an anticoagulant, get our rate down, a lot of times using some type of a beta blocker, calcium channel blocker. Then we're going to talk about these two together. Then we have to fix the rhythm. This is where we may cardiovert, okay? All right, so cardioversion is what we do for our tachy, specifically AFib is our big one. I'm going to come back to cardioversion after we talk about our 3 cardiac arrest rhythms, okay? So when it comes to the cardiac arrest rhythms, there's actually 4. Pulseless electrical activity is not one that you need to know for our purposes. However, PEA, if you decide to go get either Advanced Cardiac Life Support Certified or Pediatric Advanced Life Support Certified, in those cases, you will need to know what PEA looks like in the details, but it can be any single rhythm except for the 3 I'm going to talk about that present without a pulse. That is considered PEA, okay? When it comes to the 3 cardiac arrest rhythms, I would highly recommend that you look at the American Heart Association ACLS algorithm for cardiac arrest rhythms, okay? And I'm going to separate these into two different sides, okay? So we either have got pulseless VTach or V-Fib. Then our other side is asystole. And again, PEA also falls under here, but that is not one of the three. So of the 7, you got your 3 sinus, your 1 tachy AFib, and then you're going to have 3 cardiac arrest rhythms. Guys, no matter what, if you see one of these rhythms, the most important thing to do is what all of you know how to do. High quality CPR, right? Because if the heart's not working efficiently, what are we doing by doing CPR? We are becoming the perfusion, or the C, in airway, breathing, and circulation, okay? So when it comes to pulseless VTach or V-Fib, again, no matter what of the cardiac arrest rhythms that you see, no matter what, the number one thing is high quality CPR, all right? But for pulseless VTach or V-Fib, we can what's called defibrillate. Fibrillation, okay? And again, number one thing, high quality CPR, okay? Right? So at this point, we're going to start with high quality CPR. Next, we can do defibrillation, okay? We're going to talk about the difference between cardioversion and defibrillation in just a second, okay? But then again, no matter what, okay, we're going to continue down this process and potentially give meds. For our purposes, you don't need to know the meds, but if you decide to go get ACLS or PALS certified, you will get to know the meds going forward, okay? Asystole, contrary to what a majority of medical shows like to show you on TV, asystole, your flat line, is not a shockable rhythm. So if you see a flat line, it is not shockable. All you're going to do, high quality CPR and give medications, okay? All right? But no matter what, guys, in the cardiac arrest rhythms, you still got to go back to what caused your patient to go into pulseless VTach, V-Fib, or asystole. Again, as a nurse, you're going to look at what's called your H's and your T's, the things that cause a patient to go into a cardiac arrest rhythm. But no matter what, you see one of these, you're going to call a code if you are not part of the code team or ACLS or PALS certified, but you're going to start that high quality CPR, okay? Let's talk about the difference between cardioversion and defibrillation, okay? So cardioversion, and there is an excellent chart from a table from our book that compares the two. Cardioversion is we will use for tachycardic rhythms when we are going to hopefully convert it back to a normal sinus rhythm, okay? So cardioversion, we are going to give an amount of energy, and no, you do not need to know what that energy is, but we're going to give an amount of energy. Thing is that energy has to be on the R wave, okay? We call it synchronized. Synchronized cardioversion. If you notice, on each of my R's, I have this little dash above it. When you put a patient on a ECG monitor, you hit sync, the machine will sync up to the R, to the top of the R wave. When we are doing synchronized cardioversion, we are giving a jolt of joules in energy and it's got to be directly on the R wave. If we give it anywhere else through the cardiac cycle, there is a possibility that we could kill the patient, okay? But keep in mind, patient that is in uncontrolled AFib, they are conscious. So when we are going to cardiovert the patient, synchronized cardioversion, we want to consider potentially sedating the patient. Okay, so synchronized cardioversion hits on the R wave, and we do it for our tachyrhythms. Okay, when it comes to defibrillation, defibrillation, difference between this is now we're going to do defibrillation on our cardiac arrest rhythms, but only these two. Okay, we do not do it on asystole, nor do we do it on PEA, but pulseless VTach and V-Fib, we will defibrillate. If it is asystole, it is not a shockable rhythm. Okay, so for defibrillation, we can shock the patient anywhere throughout the cardiac cycle. Again, we're going to give them a jolt of joules, doesn't matter where it's at. These patients are unconscious. So again, trying to get that patient potentially back to some type of normal sinus rhythm, We're going to, again, potentially keep going through the cycle of CPR, defibrillation, giving meds, keep going through this cycle, but no matter what, we have to go back to what caused your patient to go into one of those cardiac arrest rhythms from the very beginning. If you look at it, your H's and T's, some of the common ones, hypovolemia can lead to a cardiac arrest rhythm. We've talked about potassium throughout this entire semester, both high and low. Hyper or hypokalemia can screw with the heart. So one of your H's and T's is both hyper and hypokalemia, okay? There are, look at your ACLS, American Heart Association, and look at kind of those H and T's. But as a nurse, guys, the best nurses are planning for potentially what can happen, right? So in that case, if your patient potentially becomes hypovolemic, they've got hyperkalemia where that T wave keeps getting higher and higher, that can lead to lethal dysrhythmias, okay? So in that case, we want to try to fix it, but in the meantime, you see one of the 3 cardiac arrest rhythms, high quality CPR. Make sure, guys, that as you're reviewing this, if you look, there is a total of 7 different rhythms that you need to know for our purposes. If you look at the game that we played, name that rhythm and name that rate, there are 6 rhythms that are on there. Those 6 are Brady sinus rhythm, tachy sinus rhythm, Afib, pulseless VTach, Vfib, and asystole. The only one that is not on there is normal sinus rhythm. And just remember, when you are reading a rhythm strip, you're going to read it left to right. You're going to count your QRS complexes as you're looking at a 6-second rhythm strip. And for our purposes, you would only receive a 6-second rhythm strip. To determine the beats per minute, we're going to take that 6 seconds times 10 to get to 60 seconds or 1 minute to calculate exactly what your patient's rate is going to be. I like to end all of my videos with something inspirational, motivational, and I want to read you a quote from Be Water, My Friend, The True Teachings of Bruce Lee. Empty your mind. Be formless, shapeless like water. You put water into a cup, it becomes the cup. You put water into a teapot, it becomes the teapot. You put it into a bottle, it becomes the bottle. Now, water can flow or it can crash. Be water, my friend. And I think that there are some excellent points in there that no matter what, water can do anything. So can you. Every single one of you have a genius inside of you. You need to find it, let that genius out, and let it thrive. I hope that this video helped you understand ECG rhythms just a little bit more. I look forward to seeing you again soon. Happy studying.